Good morning. Nice to see you all here. Thank you for the invitation. And after Zisi's presentation about clipping in the tricuspid valve, my talk has to do about replacement, transcatheter valve replacement. Practically after TAVI, that paved the way for transcatheter structural interventions, this is the first valve that becomes commercially available for use, the tricuspid valve, and not the mitral valve that probably a lot of us were waiting for a long time. Hopefully we'll have something good in the mitral also soon. Disclosures. So this is the first commercially available valve, the VOC valve, that it comes in 3 sizes. As you can see, there are 9 anchors, and this is the anchoring mechanism. It's based on both the leaflets and on the annulus. It's a self-expanding nitinol with pericardial leaflets, and you can see the design of the valve. And the procedural steps here, access, the valve is within a capsule, and then you retract the sheath. There are actually 2 sheaths inside, and gradually you release first the hooks, and then you deploy the valve. So what is the science behind it? The TRISCEND 2 trial that we've seen recently, and the approval, the CE mark approval, and the FDA approval was based on this data. From the first 150 patients in this trial, randomized trial between optimal medical therapy and EVOQUE. So from the 6 months outcomes, we see, first of all, the baseline characteristics of the patients. These are not young patients, they're elderly patients, mostly female. A high risk score for surgery, as you can see, 10% STS score. Almost all of them have atrial fibrillation, or almost 100%. And 1/3 of them had a pacemaker already inside. The main etiology of the tricuspid regurgitation was functional, as you can see, and small percentages of other etiologies. And all of the patients had significant tricuspid regurgitation, but more than half of them were in the massive and torrential grade. And here are the results. So initially, patients were in TEER grade, massive or torrential, the majority of them. And as you can see, after EVOQUE, the majority of them were in mild or non-tricuspid regurgitation. So the valve eliminates the tricuspid regurgitation. It doesn't produce the results we've seen earlier by Zisi's, like 70% success to have mild or moderate or 50% success. We're talking about 98% success. And of course, much better than any optimal medical therapy. And then, of course, as expected, the symptoms were improved in a similar fashions in these patients, and the win ratio when you do the analysis on these first 150 patients, similar to the TriLumina study, statistical analysis was significantly better, and the results much better than they expected for this type of population. And these are most recent data from all the patients, or the majority of the patients. So you see the numbers go close to 400 patients. Not all of them included in the follow-up yet, because the follow-up is still ongoing. And again, we see for all the outcomes that matter the same, better, the valve fares better than optimal medical therapy. And just to have an idea what to expect after implantation of the EVOQUE, so we had 3% mortality. As I mentioned, these patients were really high-risk patients. And then we had 10% severe bleeding, large venous access, but you should respect the venous aspect. It's not arterial, but it's still, you can still have a lot of bleeding events if you are not careful. And as you can also see, about 10 to 15% new pacemaker implantation after implanting the EVOQUE valves. So the EVOQUE valve needs a 28 French delivery system, as you can see, for the vein. and there are some specific qualifications that all come from the CT scan screening. So we need to have a perimeter that falls within these margins, 115, 160, and this for the 3 sizes we have available now, because a new size, the 56, will become available hopefully later this year probably, and then more patients will be good for this therapy. And as you would expect, the main reason for exclusion for screening failures in this study was large annulus. So that's why we expect the new valve size to reduce this rejection rate. So in our experience, this rejection rate is approximately 70 to 80%, which is much better than the mitral study's rejection rate, which is vice versa, the opposite. So I think instead of talking a lot, I'll present you one case, and we'll understand together how and when we use this valve today. So this is a young lady below 60 years old with a history of dilated cardiomyopathy, myositis related, on immunosuppressive therapy, symptomatic for many years, and we did like 6 years ago, because of severe functional mitral regurgitation, TEER, we're using 2 Pascal devices with a very good result, and she improved symptomatically for some time. Of course, as you would expect, she has CRTD, COAD, hypothyroidism, paroxysmal mitral fibrillation, some severe degree of pulmonary hypertension from the heart catheterization. You see all the medications. She was taking all the medication you would expect a patient like her to be on. And here, labs with an elevated BNP. So she became symptomatic like the last 2-3 years. And we were in contact waiting for some treatment for her tricuspid regurgitation that was moderate like 6-7 years ago, but was progressing gradually to severe. So this is her chest X-ray with all the hardware you would expect to see, the CRTD and the 2 Pascal devices. This is the image, the transthoracic image of her tricuspid regurgitation. You can see the defibrillator lead there somewhere, so you wonder if this plays a role in the etiology. And you can see the vena contracta, as Jesse said earlier, very wide, and also includes the defibrillator lead inside. So this increases the suspicion that the defibrillator lead is at least related or also participates in the etiology. This is a transgastric view where indeed you see the defibrillator lead impinging on the septal leaflet, on the posterior part of the septal leaflet here. So even if you go with clips, you'll have to use multiple clips, and it will be impossible to take this part that is very close to the lead. That's why we're not proceeding with TEER all these years, and we're expecting the valve to become available for this lady, because it's a young lady. We didn't want just to reduce the tricuspid regurgitation, we wanted to eliminate. So you see the torrential nature of the regurgitation, arrow 1.3 here. Corner is normal, as you would expect, dilated cardiomyopathy. So there was a discussion why to do the TTTVR, because we had the lead involvement, because tricuspid dilatation of the annulus was severe, because it was torrential regurgitation. And then we had some worries about this patient, some concerns. First of all, we need to clarify that the lead is not the old bipolar type that has been known to interact sometimes with the anchors of the evoke. We checked, and it wasn't that type of lead. These leads are rarely used today. And also that the right ventricular function was also impaired, moderately, at least I would say, similarly to the impairment of the left ventricular function. So here you see an animation from the CT scan. You see the movement of the defibrillator lead. There is some redundancy of the lead, which is a good thing for the treatment we're planning to proceed. And this patient fall well within the range of the evoke. So this is the implantation of the large evoke, the 52 millimeter. This is from another patient, just to show you how we start the procedure, because we didn't record this part from this patient. So first of all, we go, it's very simple. You go with an Agilis catheter, and you have to direct and advance a Safari, extra small Safari, through the tricuspid valve without using any pigtails or any swan catheters, because this way you know that all the curve, it goes through the valve and it doesn't go through chordae. This is a very important part at the beginning of the procedure. I would say the only important part for us interventional cardiologists. And then it's very easy to advance the capsule of the valve there with all the knobs that you have, and you can provide primary and secondary flex on the capsule. And once you are there, the procedure for the interventional cardiology is finished. Everything from now on has to do with micromaneuvering and with echo imaging. So echo imaging is the most important. So at the beginning, you have to go and be really coaxial to all planes of the valve. So the anterior, posterior here, you have to be coaxial, vertical. The septal lateral, you have to be coaxial, vertical. And the transgastric level, you have to be also in the center, the location, as you can see here. Once you achieve this position with the capsule, everything then becomes very easy from now on, again, for the interventional cardiologist, not for the echocardiographer. And so this is how we proceed. We start to exposing the anchors by pulling the sheath of the capsule, and then what we see at 45 degrees here on echocardiography, we use multi-planar reconstruction, as you can observe, for this procedure, 100%. And then we have to see the leaflets in relation to the anchors. We're using the anterior-posterior projection here, and then we rotate the calibers for each anchor to see exactly what is happening here with the leaflet. So we want the leaflet here to be engaged or ready for engaged or moving freely in and out of the anchor. We don't want to see the leaflet to be pinned outside of the anchor, because if it's pinned, when you release the valve, it's not going to be held there by something. So this is how we proceed. This is 90 degrees now, the anchor is exposed here, as you can see. And then here, you see you have flipping of the anchors, as we call it. So the anchors come completely back, and in this position is the most important to check again on MPR that we have the correct position and movement of the leaflet on each anchor. So we do this dialing around, all the rotation around for every anchor to check that the leaflet is engaged and is not pinned outside. So for every step of the procedure, we repeat this again and again. It's monotonous, but very, very important if you want to deploy the valve correctly. So here we have the ventricular expansion. So you see the ventricular part is now almost completely open. And then this is the full ventricular expansion. And at this stage is the last point where you can change the orientation of the device in case there are some small deviations from the right planes. But normally you shouldn't have to do that because you are in the correct position for the beginning. And again, you check for the last time the leaflets that in the correct position, and then release is really simple. So this is how the valve moves. It moves with the annulus, and you can see that the lead is compressed, but because there was this redundancy, there is no problem, so it's not pulled back. And this is the immediate result after release. This is how the valve appears in transesophageal, and as you can see, there is zero leakage from this patient, and this is the clear view of the transesophageal, where you can see the valve sitting in the position you would expect it to sit with this excellent result. And the in-hospital outcome was unremarkable, no problems, and the patients were discharged on day 3, improved significantly after this. We're more than 3 months now after the procedure, and she's doing well. And this is the follow-up about 1.5 months after the procedure, transthoracic echocardiography. As you can see, the valve is in the expected position. There is no difference from the initial result. And if I have time, very, very quickly, I'll show you this in 3 slides. This is another patient with a lot of previous procedure, 89 year. He had a TAVI, he had also TEER with Pascal in the previous years, but he also has severe TEER. So he comes back, this is the TEER, also symptomatic for some years. We were waiting for the valve also for him because we knew that we couldn't achieve an acceptable, good result with TEER. So fluoroscopically, again, as you would expect, you can see the sapien, you can see the Pascal, and then here it comes, the 90 degrees of the hooks, full ventricular expansion and release of the valve, and this is the immediate result, again, in this patient, a very good result, with no paravalvular leak and very good function of the valve. So, this is the follow-up. By closing my presentation, I would like to, this is my way of thinking, because a lot of you will come with this question, when to select TEER, when to select valve for the tricuspid regurgitation. So I think when you have major coaptation gaps, more than 5, 6, then the result is guaranteed with a valve, so you go with a VOC. If you have a lead involvement, like in the first case, again, I think you go with a VOC. You have bicommissural TEER, where you have to put multiple devices, multiple clips in both the anteroseptal and posteroseptal. We know that the results are not good then. Again, I prefer the valve. When you have all these features of torrential tricuspid regurgitation with enlargement of the atrium, enlargement of the annulus, very wide vena contractors, again, you don't want to go with a clip and like 50% success rate. You go with a valve with a 100% success rate. On the other hand, if you have severe right ventricular impairment, these patients, theoretically, but also practically, especially after surgery when they replace the valve, they have a higher possibility to go into a low output state. So probably for this patient, similarly with a patient with severe pulmonary hypertension, I will probably go with TEER if I can achieve acceptable results. And the rare patient that anticoagulation therapy is strictly contraindicated, I would also go with TEER. Finally, we come to the patients that are younger or they have large prolonged life expectancy. This is the most difficult discussion, I believe, because for these patients, if you go with TEER, you don't implant a big device, a large foreign body, but you have likely 70% only possibility to have a good result. And when I say a good result, this includes moderate tricuspid regurgitations. If you go just for mild or 0, probably this will be like 30%. So do you accept to go for a procedure that will give you these results that are not the best, a young patient? On the other hand, if you go with this procedure, then you exclude this patient for a VOC in the future. So you are done, you're finished. Now, in the younger patient, if you go for a valve, you will eliminate the tricuspid regurgitation. You will implant a larger foreign body. We don't know exactly now the antithrombotic regimen for these valves, and we don't know the durability of the valves. But we do know that we can do a valve-in-valve in a VOC. It has already been done in the US in rescue cases, and it can work. So yes, you can do valve-in-valve in a VOC. And with these thoughts of mine, I would like to thank you for your attention. Thank you.
Great. I know that this was a terrific 2 talks on the repair and the replacement, and welcome to the new world of tricuspid valve disease, and forward cardiac output heart failure, a very difficult concept. If you want to talk only about tricuspid disease, right heart failure in relation to that, you're talking about exhaustion with clear lungs. Welcome. You have to rule out lung disease. You have to work with a hepatologist to see how much the liver is involved. Often you may have to end up rule out other factors of cirrhosis, including perhaps a liver biopsy. And a lot of things that you don't intuitively talk about in the classic heart team. So we have more members now in the heart team. All of these people who never really wanted to receive a call from us, all of a sudden they say, okay, examine this patient and let us know from a liver point of view, is the liver going to come back or not? I'm not sure they welcome this call, but they are now members of our heart team, and we've got to figure out in our environment who are going to be these people who are going to be helping us with some interest in this. And of course, then you also have right side failure in relation to left heart failure. We saw some of the people, Kostas gave us already had the Pascal clips or mitral clips, this, that. So again, how much is left, how much is right? If we overcorrect the right, then we have too much volume going towards the left, then the 1 plus MR we left, maybe who knows, maybe it comes now 2 plus MR later, because we overcorrecting the right. A lot of things and a lot of, I think, combinations. Is it the clinical criterion that's going to help us? Is it the imaging that's going to help us? I don't know, maybe we can get some opinions from the panel and Dr. Shuvy maybe, and then we're coming up with the imaging and a case right after that.
So definitely the tricuspid era is on the way. And of course, there's a lot of questions. For example, who should be in the heart team? And I think that in tricuspid cases, I think that electrophysiology should be also part of it. What is the fate of this pacemaker? What will happen if this pacemaker will get infected? What will happen to the valve? Do you get immediately also endocarditis on a tricuspid valve? Because we have, they evoke, let us get excellent hemodynamic features, but still, as you said, it's a big valve. It is situated with pacemaker before and after. If you need to upgrade the pacemaker, if you need to change it, if it gets infected, if you need to take it out, those are questions that we don't really have a good answer at the time. And as you said, also, who should decide when to do the procedure? If the patient is already cirrhotic, should we do the procedure? Should we get the input of a hepatologist? I think that in generally we should try to do the procedure before the need of hepatologist view. Because when the patients become cirrhotic and they have this edema and ascites, most of the times the procedure is unfortunately maybe palliative, but not really change the course of the disease. So many questions need to be answered in order to really get the best treatment for our patients.
You are both spot on. While in aortic stenosis or even the mitral regurgitation, clinically, we don't have a lot of questions or dark points. We know this is aortic stenosis, these are the symptoms, we treat the aortic stenosis and the patient becomes better. I think in the tricuspid patient is the most complex, perplexed patient, and we need to do a very good workup before we decide to intervene. Things are not always as clear and as you believe. You're both right.
And also, if I can make a quick comment, we have this philosophical question now in this brave new world of tricuspid interventions that we're blessed with many therapies. That on one hand, we have a very simple, very safe, simple is not, but very safe therapy, which is TEER, in a narrow selected population with the potential for residual TR, but safe. And on the other hand, we have the potential for elimination with a procedure that doesn't look that difficult. I don't have the experience, but you know, any experienced operator should be able to learn it, with elimination of tricuspid regurgitation, but with quite significant complication rate. I mean, this 27% is really striking. You have 10% bleeding, you have 14% pacemaker, and where do you put the lead? It's not just having the infection. You really shouldn't put the lead inside the evoke. You should put it in the coronary sinus vein, or you should put a micro leadless pacemaker, but that involves putting a 27 French sheath inside the evoke. So these are also lifetime management considerations that Kostas actually presented. So I think we have to put everything into perspective and make a very, very careful decision about how to manage these patients.
Another minor issue, we always talk about the coaptation gap and stuff. It's important to know that those features are often very dynamic. For example, if you have a patient with a very large annulus and coaptation gap, you can treat him for a few days, 3 days, with diuretic, and you get better results. You go to the procedure in a better situation. So I think that in many cases, it is treatable before in order to get a good result in the procedure. Because if you start with very torrential in a TEER, you won't get a 0 TR, definitely. But if you treat the patient before and optimize his medical therapy and maybe give him a few days before, and you get to the procedure in moderate to severe or severe TR, your results will be much, much better.
Great, thank you, Costa. Let's move on. Invite Dr. Ninios